everybody, welcome back. Hey Jake.
Hey.
Cheers. It's our green Pilsner today, right?
Because we're celebrating St. Patrick's Day,
We are.
even though it's way past when you guys are watching this.
I know, it's March 15th today, so we just felt like we had to either do this or celebrate the Ides of March, and this seemed a lot more positive. So, so today we're talking with, I'm Megan Cranenberg. I'm a physical therapist. I own Chrysalis Physical Therapy in Poulsbo, Washington. This is my YouTube channel. And this podcast is Pints and Pelvic Health, where I get to sit down with really fantastic people talking about important topics related to bowel, bladder, and sexual function for all people at all ages in life. And today, again, my guest is Jake Bartholomew. And Jake, why don't you go ahead and do a quick recap on who you are?
Sure. I'm Jake Bartholomew. I'm a pelvic health physical therapist in Seattle at Flow Rehab.
We'll link to Flow Rehab in the comments so that you guys have that link to, if you're over on the Seattle side and something about this resonates with you and you think, I need to go see Jake, or hey, my boyfriend or my husband or my partner could use some time with Jake, then you'll know just where to find him. So today's topic, male pelvic health. Specifically, what did you want to talk about today?
Male pelvic pain is a large part of my patient population.
What would that be? Who gets categorized as having male pelvic pain?
That's, again, a great question. There are all sorts of pain or things that start getting lumped under pain, because it could be sexual dysfunction too, or sometimes pain after sex or during sexual intercourse, as well as pain somewhere in their pelvis, or they feel deep in their pelvis, they're not quite sure where, and they feel it might be prostatitis or something similar.
You mentioned prostatitis in last week's episode and how that was kind of what we would say like an umbrella term.
Absolutely.
Which aren't like sciatica. Oh, got the sciatica, boss. Like, what does that really mean? So talk to me a little bit about the evolution of prostatitis and where you're starting to see differentiation with that.
Yeah, that's exactly it. It's been a really big umbrella term and kind of a catch-all for male pelvic pain for a long time. Is kind of the history of it, I think. And then as people start to dive into it more, doctors do more research or more testing, and they're seeing less bacteria or no bacteria. Then they're trying to figure out, what do we do now? Because we've been lumping it under prostatitis for so long and inflammation of the prostate. And so then they've created subcategories of bacterial prostatitis and non-bacterial prostatitis, which still confuses me as to exactly what
Could we call it what it actually is then?
Yeah.
So how would someone be ruled out of, if it truly is a bacterial prostatitis, how do they rule that in that that's what's going on?
Yeah, so normally they'll culture that. So they'll test the urine for bacteria, or they'll actually perform massaging the prostate for secretions and testing that. But even that's not always super conclusive or coordinating with their pain, but that's usually what they're doing right now.
What are the kind of symptoms that a guy would have and think, oh, maybe it's prostatitis, and then the doctor go, I think what you're having is prostatitis. What would he be saying?
Yeah, so a patient, it could be a variety of things. Often for the patient, they're saying there's pain down there somewhere. It feels like it's inside my pelvis.
Okay.
And so usually if the patient can't push on it and recreate the pain somewhere, and that kind of scares them, and they may or may not think prostatitis, or then they're going to the doctor who is probably thinking prostatitis.
Okay. So they have to have a positive culture, maybe to be a bacterial prostatitis, and then does antibiotics just always magically fix all that? Yay! And now you're better.
And sometimes I think they're not cultured, and a doctor will just try antibiotics to see. They feel it's kind of a safe trial to see does it get better, and then that kind of helps them confirm the diagnosis.
Okay.
And so they give them 2 or 3 weeks of a strong antibiotic, and if that helps, then they'll say, okay, that's what it was.
Okay. So are there problems with that approach?
Absolutely. So antibiotics could affect their gut and their GI system and decrease, their gut flora and give them, bowel issues. Sometimes I think the antibiotics have a little bit of an anti-inflammatory effect and might improve whatever is causing their pain. And so they'll get kind of a false positive that the antibiotics did help their symptoms, but then their symptoms come back pretty quick because it wasn't truly a bacteria. And so then their pain comes back. And so they might then get another round of antibiotics because the doc's thinking, oh, maybe we didn't get it all, and so we need to do it longer. But I still think in a lot of these cases, it's something else going on.
Okay. So that leads us into what's the other things that are going on if we're non-bacterial prostatitis?
Right.
And if it's not bacteria, there's so many. I mean, the pelvis is a super busy place. I almost wish we had a model with us here, some anatomy diagrams, just to say, like, look at all the other things that are stacked in around your prostate.
Exactly. But yeah, we don't have time to do what right. The male pelvic health course is 3 days, and still could be stretched to 4 longer.
Oh, easily. You're always learning. We're always learning so much new stuff. Every time I do an internal assessment with a client, I sit down with my pelvic model and I teach them through the bones and the different layers of pelvic floor muscles. If anything, because every time I talk through that with someone, I'm learning new stuff.
It helps us too. Exactly. And there's like 27 muscles and even more, nerves and tissues down there. So there's many sources of pain in their pelvis that we need to tell them about. And most men have no clue about the muscles in their pelvis.
Or women, right?
Yeah,
I saw a friend of mine posted a quote the other day, like I think she just pulled her Facebook followers or something. When was the first time you heard the term pelvic floor? And someone wrote back, last week, and I have 4 kids.
Wow.
So the gender gap's pretty good on that one. So kind of maybe hit me with the highlights, like maybe your top 3 or 4, like what are the things that you commonly see as really the root cause of male pelvic pain?
Yeah.
If it's not the bacteria inflaming the prostate.
Yeah. So most recently, that kind of makes sense as a couple cyclists that had either a change in their bike seat or a new bike and kind of change in fit. And, that kind of makes more sense, right? That if the fit's a little bit different, they're having a little bit of discomfort or a little different angle, pulling tissues down there, that they might be tightening those muscles more. But then that leads more to what I really see frequently is a muscular cause of their pain, but a lot of time there's no trauma or nothing obvious like a new bike seat. It's more, I think, a lot of stress and anxiety. Okay. And so many people hold stress in different parts of their body, muscularly, shoulders or back, but a lot of men will hold it in their pelvic floor and not know it, and they're holding tension down there. And it's not obvious because the dysfunction and the tightness increases gradually over time. And so it's not like, oh yeah, my new job started 3 years ago, so it's probably not that, even though it's been stressful from the start. I'm like, well, it could be because
accumulation over time, right? It's like a toxicity.
Exactly.
There's I need to look up, I'll try to find the source article for this and link to it in the comments, but in some of my training I've been taught that they did like EMG studies for folks and put them in like watching something where like it was a horror movie or something with disturbing images, and find that the first muscles that contract when you feel afraid or threatened are your pelvic floor muscles.
Exactly.
So if you're walking around all day at a job where you're always kind of like, ooh, I better make my sales quota this month, or that absolutely has an effect on that.
And they don't know it. Just a lot of people are not aware when they're contracting, or especially if they're doing it for a long time, it's a real light contraction. They become numb to it. It's just like getting used to a smell or something, or they're just unaware. And with time, that leads to dysfunction.
Yeah, absolutely. Absolutely. So what else? So muscular causes, bike seat changes, kind of chronic pelvic floor tension. Anything else? Like, talk to me like
a couple
causes.
Others. Yeah. I've seen like one guy who had an undescended testicle that wasn't repaired until he was like 20.
Okay.
Which is really crazy, right? And so that meant surgery through inguinal canal, and so now it's helping work on some of the scar tissue in that inguinal canal region. Yeah. And another gentleman with testicular pain, he couldn't think of a reason. And it seems like it's traced back to getting a different car and a different change in his car seat. And I think also some stress in his life that he hadn't addressed. Yeah. And so his tension has been, turns out, more around his inguinal canal and spermatic cord and into his abdomen. And so working on all that without even touching his testicle has really resolved most of his pain.
Awesome. Yeah, that kind of that lower. So when we're talking about the inguinal canal, I'm going to just stand up real quick. We're talking kind of about this area through here, common place of hernias.
Mm-hmm.
So I had a male client a few years ago who, a few years post hernia repair, suddenly he's having pain in the right side of his testicle, pain with ejaculation. He's in his mid 60s. He's a strapping guy with a beautiful wife, and they'd like to continue to enjoy that relationship for a long time. And amen to that. And it was, he had a referral from a doctor as pudendal neuralgia, right? And the pudendal nerve is too deep in the pelvis to talk about today. But that's not what it was.
Right.
It was just
Right.
a different nerve that comes around through that mesh from the hernia repair and was just kind of erratically firing. And, we'll get into treatment here in a second, but just kind of being able to go to a provider like Jake, who's got the orthopedic background to it, and is looking at each person individually and tracing things back to the root causes that actually make sense, and not just necessarily throwing unnecessary and potentially dangerous medications at it. The antibiotics are great. I'm glad that we have them. They've saved a lot of lives, but research is pretty clear that we have overused those, and they've really impacted as a society that we're so much more resistant to normal bacteria now.
Right. And having said all that, we still have to be very aware there are some very dangerous things that could lead to pelvic pain.
Yes.
And
Please.
there could be a tumor or cancer in the testicles or penis or in their pelvic floor or other abdominal issues and infections that really could cause pelvic pain. And in places like Washington that have direct access and patients can come directly to physical therapy, we have to be very mindful that there could be a more serious cause. And usually by the time they get to me, they have seen a number of providers, normally because right now patients' first thought is not physical therapy for their pain. Right?
Every week it's like, there's PT for that?
Right, exactly. So most of the time, by the time they get to me, they've had every test and imaging done and all bad stuff's been ruled out. But just want to give that reminder that there could be a dangerous cause, and I do not want to underplay that.
Absolutely. I think that's a huge part of where physical therapies move to the doctoral education is we learn those red flag questions to ask. We learn that differential diagnosis. And as a profession, we're really good at asking those sensitive questions to make sure it's a physical therapy problem and not something that we need to kick you back to your doctor.
Right.
If something seems fishy or it's not related to muscles and nerves and joints and ligaments, then we're pretty good at doing that.
Yep. If we can't reproduce the pain or recreate it predictably, then we gotta start thinking of them getting checked out more seriously.
Absolutely. All right. So awesome. We talked about some of the conditions. Join us next week. We're going to go into a little bit more details about how do we approach this then in our clinic with the tools that we have in the physical therapy toolkit to get people back on their bike, back in the saddle.
That's right.
Okay. Thanks.